Hi everybody, I'm Genia, one of the midwives at Generations, and I am here with Liz from Seaway Physio, and Liz and I are sitting next to each other on the exam table. I have no pants on. There's the paper sheet, and we are here today because Liz is going to do an internal exam as part of a pelvic floor assessment, and Liz is a pelvic floor physiotherapist, and her work is to help women that have, women that haven't had babies to regain their pelvic floor health, which is super important. So I don't know if you can tell, but my hands are shaking a little bit because I am going to lie down and spread my legs on Facebook Live. You will not see anything, but there you go. Nobody likes to have exams like this, but it's super important because your pelvic floor health matters. So I'm going to hand this over to Liz here, and she's going to talk about why your pelvic floor health matters, and a little bit about pelvic floor physiotherapy, and talk a little bit about the conversation that we have already had and what you can expect at your first pelvic floor physiotherapy appointment. And then we'll move on to the exam.
Hi guys. Genia is extremely brave. I can't believe how brave she is doing this. I'm not sure if I would have enough guts to do this, and I do this for a living. Anyway, and it just sort of goes to show that everybody is nervous on their very first exam, but almost all of my patients tell me, and for any of my patients that are watching this, please don't hesitate to comment and reassure my patients that hopefully are watching this and want to come but are maybe a little bit nervous about what to expect, that it's really not that bad. It's very much a collaboration, and it's very much teamwork. You give me information, I give you information, so you're coaching me, I'm coaching you, and it seems to be very much a non-intimidating experience once we get started. So sometimes we just kind of get going, and sometimes we have a very long conversation first. What to expect on the very first visit is almost always we just sit and talk. Everybody has a lot to say. A lot of times, especially my pelvic pain patients that have been shunted from specialist to specialist and have been told basically that they're crazy and that there's nothing wrong and the pain is normal and use more lubricant. Those are the patients especially that have a big story that they want to tell me, and I want to listen. I want to hear everything that they have to say, and it's very validating when they hear that, yes, there is something wrong. Often it's the nerves that are just sending your brain the wrong message, and we have to retrain those nerves to send your brain the correct message and retrain your brain to hear the correct message coming from your pelvic floor nerves. The other thing that we look at the circulation, we look at the musculature, we see which muscles are working, which muscles aren't working, and then we attack whatever is not working in a very gentle, non-intimidating way.
Not attacking way.
Yeah, we attack it, but not an attacking way. We say that in physio, is that we find the area of problem, and that's what we focus on. I should have said that instead.
So can you talk a little bit about why pelvic floor health matters?
Pelvic floor is really important. Basically, our pelvic floor, right there, is... Whoa, sorry.
Yeah, that's okay.
Sorry. Our pelvic floor is the core of our entire body. It holds up all of our guts. It also stabilizes our hips, our sacroiliac joint, and our low back. And it holds up our bladder, it supports our bowel, it holds up in females our uterus. And if there's a dysfunction there, if there's weakness, if there's tightness, if there's pain, it obviously isn't working well. And that lack of function over the years usually doesn't get better. It usually gets worse, and then you end up having massive leaks or prolapses or more pain.
What's a prolapse?
Prolapse is when the wall of the vagina, either on the front or the back, it gets stretched and kind of bows down out of the opening of the vagina, or if the uterus kind of telescopes down through the vagina.
All right. So Liz was saying her first, there we go. Okay, so at her first appointment, usually Liz does a lot of talking, or there's a lot of conversation and questions. So prior to going live, Liz asked me a series of questions, including what my symptoms were. So here it goes. So I cannot jump on a trampoline without peeing myself. Sometimes if I sneeze, I will leak a little bit of urine, and if I have held my bladder for too long, again, sometimes I will leak a little bit of urine. Liz asked me whether or not, she asked me about my obstetric history, and my obstetric history is that I had a cesarean section for my first baby and a vaginal birth for my second. I did have, after my cesarean, she also asked me about pain during sex, which I don't have, the pain, not the sex. I don't have any pain now, but I did for years after my cesarean. And then after my vaginal birth, that's when I developed a cystocele and a rectocele. And a cystocele is that bulge on the front of your vagina, and the rectocele is a bulge on the back of your vagina, which over the many years since I had my kids has resolved, or at least I think it's resolved. Liz will tell me. And one of the other things that Liz asked about was whether or not I had any history of trauma that might affect how I experience a vaginal exam. And we know that a shocking number of women are going to have had some traumatic experience during their life. So really for me, I just have a generic run-of-the-mill hatred of being in stirrups. My only real negative experience that affects vaginal exams is that I had, during my first birth, I had a really traumatic sort of obstetric incident that happened. But I don't really feel like it affects me all that much at this time. And I'm saying this stuff mostly so because, you know, this stuff matters, and it's okay to talk about it, and it's okay to let Liz know about it. What else did you ask me that I'm forgetting about?
I think that's it. Leaking,
Okay.
pain, prolapse, any heaviness. And is there anything else that we haven't talked about that you want to discuss? Anything that makes you nervous about what we're doing? Anything that I haven't asked you that you want to share?
I don't think so.
Okay,
We'll see how it goes as we start the exam.
Okay.
All right.
Yeah. See you in a bit.
Okay. All right. So give me a second here. I gotta lie back here. Liz is putting her gloves on as per appropriate infection control. Just one second. You're gonna look at the ceiling for a second. Okay. So, I am lying back. Basically, I didn't realize, but Liz said no stirrups actually. So I am just lying on my back with my knees up, and
I think it's more comfortable without stirrups. Plus, it gives me a place to put my elbow.
there you go. Okay. So some of the things that people say to me when I'm doing vaginal exams as a midwife are, I'm really sorry, I haven't groomed down there. So Liz, let's just see here.
I don't care.
Do you care?
I do not care.
And what about the, I don't know, what are some of the other things that people talk about being uncomfortable about?
Yeah, I often hear, I'm sorry I didn't shave my legs. I'm sorry that I'm so hairy. I'm sorry a million things that, especially as women, I think we're quite self-conscious of our genitals as a general rule. And I've said before, I'm not your lover, I'm your physio. I actually genuinely do not care. I don't care if you have hairy legs. I don't care if you're shaved. It literally makes no difference to me.
Great. Okay. So, I, by the way, have not shaved my legs in a very long time. So.
And I don't care.
Great. Okay. What do I need to do now?
Okay, nothing. You're already doing it.
Great.
So basically, the first thing I'm going to do, just so that you're aware of what's going on, is I'm just going to take a look down here. So if you can also see, this is how we sit. I'm sitting beside you. I'm not buried down here. No, this is good. Yeah.
No, I'm just showing.
Oh, okay.
There's my knees.
So I'm sitting here, and Genia and I are face to face. My head's sort of not over here where Genia can't see me. So the first thing, the only thing that I am going to be like that is when I want to take an overview. I want to look at sort of the coloring of the flesh down here to see, and that gives me clues, right? It gives me clues as to How efficient is the blood flow? Is there any skin tearing? Is there any irritation? And then we're going to look for prolapse. And then after that, I'm all back up this way. Okay? So
right.
I'm disappearing for a sec. Okay, so let's take a look here. And so we'll just kind of take a look. Oh, everything looks great. Yeah, your coloring looks awesome. You have very...
Excellent. I have an appropriately colored vulva. That's good.
That is good. All joking aside, because that means your blood flow is good. That's great. Everything looks good. I don't see any areas of irritation. So now we're going to take a look and see if there's any prolapse. Let's see if that rectocele and cystocele, that front and back wall, have truly resolved. So what I want you to do is just lift your head and shoulders up and then give me a big cough.
Maybe I should have peed before.
Don't worry. Listen, I'm wearing gloves. It makes no difference at all.
Okay, so far Liz has just basically like touched my labia and my vulva. She's not done any internal exam at this point. Okay, so lift my head and shoulders and cough.
Almost like you're going to do a little crunch.
All right.
And then we just want to add some pressure there. Now give me a big cough. Cough, 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 cough. Cough, cough, harder. There you go. Good. That's good. Okay. And I did not pee myself. No,
this is good.
No, and it wouldn't matter if you did, right? That's
great.
Sometimes.
But the fact that I didn't pee myself is a good sign about my pelvic floor health.
Yeah. And when the reason I have someone cough is that because you're laying down, gravity's not pulling down, and so I try to sort of simulate that pressure coming down through there with that cough. And there was just a little bit of tissue movement, which is what we expect. On your back wall, Genia, it's probably 80%.
80% bad or good?
80% good.
Okay. 20%
a little bit more bulgy than I'd like to see, but it's like maybe a grade 1.
Okay.
Very, very good.
So how many grades are there?
Oh my goodness, I think there's, well, either grade 3 or grade 4. And a grade 1 is just a little looseness, sort of where, and I hate to use the term loose because it's not loose. It's a little loss of elasticity. Grade 2 is the tissue is sort of down to the opening of the vagina. Grade 3 passes the vagina, and I'm not even really sure a grade 4 is like a certain amount past.
Okay.
A grade 1 and a grade 2, almost always we can clear up using conservative methods through pelvic physio. Grade 3, it's usually 50-50, depends on how compliant my patient is and often how elastic their tissue, how much their elasticity, their tissue regains. At grade 4, usually it's bulging out so far that it's really getting in the way of the tissue so much that's the time where I say, okay, let's contact the gynecologist and have them get rid of it. But in the meantime, while we're waiting for the surgery, we're going to strengthen those muscles. We're going to increase the tissue elasticity and get your body as strong and as elasticy and as stable as we can before surgery.
Okay. So how common are the different grades?
That's a really good question.
Just generally in your experience.
Grade 1s are quite common, especially after childbirth, and super duper easy to fix. Grade 2s, I would say probably a quarter to a third of my patients have a grade 2, either front or back wall. And uterus is a little bit different because it's more of that sort of the uterus is kind of coming down this way, and it's more of a ligament issue, and we work more up on the stomach and sort of we do a little bit different stuff for that. And grade 3, I don't know if it's because usually those are the patients that don't see me. They're the ones that probably go straight to their gynecologist. I don't see them as often, or if I do, we work with them, get them as good as we can, and then I send them to their OBGYN, and then they come back to see me after their surgery.
Okay. All right.
Okay. All right. You ready?
I'm ready.
Okay. So no concern. So I'm warming up the gel in my hand.
Thank you for that.
You're welcome. It's still probably pretty chilly because we're such nice warm creatures. Okay, you ready?
Yes.
So now I'm just sort of checking to see if there's any sensitivity sort of on your labia there. Does that feel okay?
Sure, it doesn't hurt.
No pain there?
No
okay,
pain.
Great.
So Megan is clarifying the first visit is just talking generally?
As a general rule, if somebody is very anxious, sometimes we'll do it just to kind of get that first visit over with. But as a general rule, it takes so long to kind of get through everyone's story and to talk about different treatment options. And I'm a really big believer that by the time we get to this point, you should feel confident and comfortable and know exactly what we're doing and why we're doing it.
Okay.
Okay. How are you doing there?
Fine.
Okay.
I don't usually have conversations with people while somebody has their fingers in my vagina. Okay. So right now, I can feel Liz's one or two, I can't
Just
really
one.
tell, one finger in my vagina and a little bit of pressure on the back of my and sides of my vagina.
So I'm just sort of at that vaginal opening. I'm just kind of feeling around to sort of see what we feel here. And it actually feels really good. Your muscle here, does that tender a little bit?
That hurts.
Yeah.
Well, it doesn't hurt.
No,
it's not comfortable.
Like I'm poking on a sore muscle, right?
Yeah. So she's like poking me on the right side of my vagina, just a little ways in, and it doesn't feel good.
And how about over here?
That also doesn't feel good.
Yeah, your muscle sphere. So it's hard to put into words what you're trying to feel with muscles, but over the years you kind of get a feeling. You want when you touch a nice healthy muscle, it should feel kind of not soft, but kind of like pliable and springy. And on this muscle here, sort of on the muscle on the sort of the side walls here, there, and right over there, they're quite sort of stiff feeling, and they feel, it seems weird for someone else to say, but it feels sore to me when I'm touching it. It feels like it would be sore. But the other thing is, this is a little tiny bit of a high stress situation probably for Genia. So let's see if maybe she's just sort of clenching a little bit, telling me to get the hell out. All right, so ready? Give me a little squeeze. Like squeeze around my finger and relax all the way down. Good. Good. All right, let's see if that feels any better. Is that sore?
No, it is on the left.
How about over there? Yeah?
Yeah, that's uncomfortable.
That's it, yeah. So basically what's happened, that feels better.
Still is not comfortable.
Yeah, it feels
less uncomfortable.
Yeah. So you've relaxed a little bit, but I still think there's a little bit of an underlying sort of chronic muscle-y spasm there. So this is the muscle that's one of the closest muscles to the outside, to the opening of the vagina. Okay, so I'm going to go just a little deeper and we'll see sort of the next sort of layer of muscles there.
Okay.
So
that's uncomfortable.
Yes, I can feel that right away. Right inside there, eh?
Yeah.
Yeah. Okay, sorry about that. If anything I do causes you too much pain, or if it's more than just me kind of poking on a sore muscle, you let me know right away, okay?
Yeah.
The last thing I want to do is cause you any pain. I just want to sort of feel which muscles are working and which muscles aren't. How are you over here?
That's not comfortable.
Yeah. Like just a weird pokey feeling or sore?
No, it's like, I don't want to say it's painful because that would be an exaggeration, but it's not. It's actively uncomfortable.
Yeah. Let me go. How does that side compare to that side?
That's less uncomfortable.
Okay, good. So I'm going to check. There's one little muscle that tends to be a bit of a bugger when it comes to muscle spasms, called the internal obturator. So I'm just going to kind of reach around here and just feel my hand there on the outside of your knee.
Yeah.
Just gently push your knee into my hand towards the wall. And relax. And again. So right there is your internal obturator muscle. How does that feel?
That is quite uncomfortable.
Yeah. Let's check on this side now and see. And push your hand into me, or your knee into my hand, and relax. And again, and relax. How does that feel?
That's, it's like you were going on and off something, so at some point that's uncomfortable there.
There, eh?
Yeah.
Okay. Okay, so that's the internal obturator muscle. The internal obturator is a really cool muscle. It starts really at the top front, wraps right around and attaches onto sort of the back of this hip bone down here. So it's really cool because it forms part of the sort of the vaginal, the pelvic floor wall, because the pelvic floor is almost like a bowl, and the internal obturator muscle is sort of the wall of that bowl. And then it attaches onto the back of the hip bone. And oftentimes I'll have patients that come into me and they'll be like, how did you know my hip hurt? And I'm like, well, because that muscle is sore in your vagina and it can make your hips sore too.
Do you ever chronic hip pain?
You do have chronic hip pain? Yeah, okay. That doesn't surprise me because that muscle that I just poked that's sore inside you bet you, I'm going to bring my finger out and I'm just going to sort of push, right? So I have to so we can hit sort of that, where are we? There we are.
Yeah, that hurts.
Yeah.
So Liz is poking around on the outside of my vulva now, like...
By your sit bone.
Yeah.
How's that? Yeah, sorry. So that was right. So if you're looking at someone's buttock and that sit bone that, you kind of sit on somebody and dig your hip bones into, the internal obturator muscle comes right along the inside of that bone. And I can often feel it I can feel it very well inside someone's vagina, but I can also feel it very well sort of externally there. And then if we really wanted to, I could kind of dig in over here on Genia's hip and sort of find the other end of it. There's a really cool stretch that I'll show you afterwards that can really affect this. So, okay, you ready? I'm going to go in now and we're just going to check your strength, okay?
Yep.
So what we found so far is the cystocele and the rectocele are pretty much fine. The muscle spasm that we see is probably contributing to that little tiny bit of extra tissue movement on that back wall. And once we get that, I'm very confident that will go away completely. So I don't think we need to worry about that. The challenge is that oftentimes when people think about leaking and pelvic floor problems is they think just about weakness, and they don't realize that like in your case, Genia, you're the perfect patient, because that muscle spasm. So if this is a fully contract muscle and this is a fully relaxed muscle, a spasmy muscle is kind of stuck like this, and it's not contracting functionally, so it's not kind of cinching things up, it's not supporting things, and it's not sort of tightening up around that urethral opening where the urine comes out properly, and it's not supporting the rest of your organs properly because it's really sort of only halfway contracted, but it's kind of stuck there, and it's not relaxing all the way, so that's making it sore, and that's kind of where you're kind of stuck there. Okay, which is kind of cool because it's actually a pretty easy thing. We just have to retrain those muscles to contract past that muscle spasm and then relax past that muscle spasm, which is very doable.
Great.
Okay, so now we're going to check your overall strength, okay?
Yep.
Okay, here we go. And we're just going to go here. And so go ahead and give me a little squeeze.
I feel like I can't right now. Okay, hold on.
Yeah, okay. Just think, so what I want you to visualize is just think of sort of lifting your anus up, closing the open, there you go. Closing the opening of your vagina, pulling your clitoris. Everything is aimed up towards your belly button. That's it. And relax. Now, good job. Make sure you're not using your tummy and you're not using your glutes. Okay?
Okay, hold on.
Okay.
Oh,
Take
no,
some concentration. Take some concentration.
Okay, hold on here. This is a lot harder than it sounds. Okay, hold on. So I can't use my stomach and I can't use my butt cheeks.
Yeah.
And
breathe. And on top of that, you have to breathe too. And relax.
I can't tell if I'm doing anything really. I feel like my vagina is twitching. That's what I feel like.
Give me another squeeze. Let's try it again. Pull everything up. Close the opening of your vagina. There you go. That's it. And relax. Do you want me to tell you what your strength is and how we grade it?
Yes. All right.
Sure?
Yeah.
Okay.
Terrible, right? If you just have a twitchy vagina, that can't be very good.
No, it's not terrible. It is what it is. So, and the good news is that part of the problem, I think, is weakness. And so I scale strength on a scale of 0 to 5. And 5 is perfect. You can squeeze everything closed, and I can't sort of force my finger to break that contraction. A 4 is you can squeeze everything closed, but then I can sort of gently push on those muscles and then they give way. 3 is you squeeze more than halfway. 2 is you create movement, but it's less than halfway closed. 1 is you are just kind of twitching, and that's a 1, and a 0 is nothing. So I would score you somewhere between a 1 and a 2.
So that's like a D to a C minus.
Probably.
Is my vagina failing right now?
No.
So also there are lots of comments going by Liz that there are people all over watching this, squeezing their vaginal tissue.
Perfect. Good job, guys. Good job. But don't forget that it's just as important to relax as it is to squeeze, right? There's two parts to that. You have to squeeze up to strengthen, but especially in Genia's case, because she's got some muscle spasm there, we have to train those muscles to relax too. That's just as important. And oftentimes they kind of go into spasm because they're very weak. And then if all we're doing is strengthening, it will actually reinforce those muscle spasms. We have to train them to contract properly and then train them to relax properly too.
Right. So just focusing on kegels is not always a good idea.
It's very gone are the days when we can just sort of crank through stuff. It's all about being mindful. It's all about mindfulness. And I'm throwing this out there because I don't know if this is what's happening with you, but sometimes people, when you're stressed or you're rushing around and your shoulders kind of come up and you're like clenching your teeth and you're frowning and you're kind of doing that. Oftentimes what happens is we clench our vaginas, or what happens in men is that they're drawing up their testicles, or they're clenching their anuses as well. And oftentimes you have to be very mindful of that sort of stress reaction, because we can work for a ton of time, and let's say you have a really busy day, or you're rushing around, or you're doing something, and then unconsciously you're kind of clenching everything down here, and it will undo the good that the hard work you've just done. So it's just all about mindfulness. It's about mindfulness with contraction, mindfulness with relaxation, and sort of being aware of your body during your activities of daily living too.
Yeah. So when people are giving birth, I will often remind them, soft jaw, soft tongue, because the tension in your jaw and your face directly relates to the tension in your pelvic floor, and we want that to be soft.
I wish you had been my midwife when I was giving birth. No one ever told me that. So the other thing that we need to look at as well, it's not enough just to say you have weakness here and muscle spasm here. That's not enough to say. We have to say why. So why are you having weakness there? And one of the potential causes, and I don't know if this is what's going on, but one of the potential things is connective tissue. Connective tissue covers us head to toe, and it kind of goes through our muscles. If you pull steak apart, you see those little spider webs on the inside. That's connective tissue. And then on cheaper steak, that sort of shiny sheath that goes over top, that's connective tissue as well. And the main characteristic about connective tissue is that it's not stretchy. And so when we move, we're very stretchy, especially women's vaginas. We're extremely elastic down here as a general rule. But what can happen in some people sometimes, that elasticity, there's no elasticity in connective tissue. Those little fibers, there's a chemical change and they become sticky. And they stick to themselves, they stick to the structures above and the structures below. And if you can imagine on my sad little bicep here, when I contract, that muscle gets shorter and fatter. But if I've got a sheath over top that is now stuck to that muscle, it doesn't allow that muscle to move normally and kind of bunch up as it contracts. So it inhibits that muscle contraction, and our muscles are going to do one of two things. They either stop working or they go into muscle spasm. And so that's what we're going to look at right now. And the way we look at that is we just sort of lift the tissue on the surface and kind of roll like this, because on healthy connective tissue, it just kind of, there's enough built-in slack that it just kind of gives it.
Did you just say you're going to pinch my vagina?
No.
Say that again.
Let me rephrase. Good call. No, what I'm going to do is I'm actually just going to, I guess pinch, but not in a way that should hurt. I'm just going to hold your skin sort of between.
Okay, you are going to pinch my vagina. Okay,
I guess,
fine.
yeah, I'm going to pinch it, but it's not going to hurt.
I'm good with that. Okay.
It's more, not pinch, I'm like lifting that surface tissue. So I'm going to kind of hold it this way and lift it and just sort of drag down this way. If there's no connective tissue problems, you'll go, piece of cake, just felt some pressure as you sort of went down there, doesn't hurt at all. If there is connective tissue that's sort of stuck to themselves, and it's inhibiting that muscle contraction, you're going to go, ooh, that kind of hurts a little bit. Then it will kind of feel like I'm pinching you.
Okay. And
we'll know whether or not the connective tissue is sticky down there, because if it doesn't hurt, you're fine. And if it does hurt, then you'll go, ooh, okay, that is what's going on. Okay? Are you ready?
Yeah.
All right, here we go.
All right.
So I really don't pinch you. Okay, you ready?
Mm-hmm.
Here we are.
So somebody was told by a physio that they
Oh, wait, please.
sorry.
No, go ahead. What were you saying?
This was starting to pinch my vagina. It's very distracting. Okay. So somebody was told by a physio that that they had too much tension. Is that what you're describing?
Mm-hmm.
That's just
that's exactly what we're talking about.
And
that's some tension and muscle spasm. People use different words for the same thing.
Okay. And does anybody who has a baby ever come out with a 4 or 5, like an A+ vagina?
Like without strengthening afterwards?
Yeah.
I've never seen it.
Right.
Yeah.
So,
but you can get back to that.
So one of the reasons for pelvic physiotherapy for anybody who's ever had a baby is to get a 4 or a 5.
Yeah, and I mean, a 4 is very functional. Like 5 is you're like Superwoman down here, but you don't
if you're
have
not lifting weights with your vagina, you don't really need a 5.
You don't really need a 5.
Excellent. Okay, good to know.
4 is perfect, and and it's all about function, right? I have women that start off with 0 and they work their butts off and they get to a 3 out of 5, and they're great. Like they have no prolapse, they have no leaking, they have no pain, they are feeling strong and stable. 3 is good because that means you're strong enough to lift everything up against gravity. So if you're happy at 3 and you're not having these symptoms, as long as you continue to strengthen, I'm happy with a 3 because it's all about function, right?
Okay, great.
Okay.
All right, go ahead.
You ready?
Pinch
Here we
me.
go. So I'm not pinching.
This is
I'm holding like this.
Liz is really not pinching, and this is on the outside of my outer labia. This is not.
That's exactly right.
And towards my butt. This is not internal.
No, so I'm just.
That's not comfortable.
Yeah, and you can kind of feel too. So what I'm feeling is it's hard to put into words. Like I'm feeling sort of smoothness of them right there.
That hurts.
Yeah, and I am just exactly even with that back wall that has lost some elasticity. So we know from this right there. Mm-hmm. Oh,
Woo!
sorry. Yeah. And what it feels like, if anyone's ever had kind of like almost like a Charlie horse, that same sort of feeling, like a calf spasm or something along those lines, it kind of feels like that, eh? Would you say? Or no?
No, I wouldn't describe it like that.
No, how would you describe it?
I don't know how to describe that discomfort. I guess it feels like a deep bruise or something.
Okay. Now, I've done about 4 or 5 passes over top of it. How does it feel now compared to the first time?
Less sharp.
Good. Let's do just a couple more, and then we'll try the other side. So already you're not wincing anymore.
Yeah, no, it's not as sharp.
Sometimes it only takes a couple times to kind of get that connective tissue loosened up. Well, are you nervous still, or do you feel okay?
I feel fine.
Good.
I'll still be happy to put my pants back on.
How does that feel pain-wise?
It's much less.
Good. Okay, we're going to go to this side now. Okay, you ready?
Yeah.
Okay, here we go.
That's quite uncomfortable.
Yes.
Okay.
Yeah, okay. So we just have to go gentle. We just have to be gentle. You okay?
Yeah.
You're so brave. I can't believe you're doing this. It's awesome.
So somebody's asking whether the multiple passes is loosening everything up. So it does. Yes, I think what's happening basically is that Liz is stretching the connective tissue.
Yeah, just trying to break up those abnormal bonds where they stick to each other. Yeah, that's actually, this side is almost smoothing out faster than the other side. Does it hurt as much?
It doesn't hurt nearly as much.
Yeah. Just
but
that
it hurt
first.
more at the start.
Yeah, but it eased up right away. I'm actually surprised that you don't.
Sister calling. She's probably not watching this Facebook Live if she's calling me right now. So
yeah, that feels a lot better.
So once that's like, is this like a one and done kind of thing?
No, because what happens, so there, I'm done now. So let me just take off my glove here for a sec. Okay, all done. That was it.
Great.
So what happens with that connective tissue? I had to talk with my hands. Did you want to sit up?
Do you want to sit up? Hold on, I'm going to turn the phone around. Okay, I'm going to sit up, and Liz is going to continue.
Hello. Someone said, I'm very disappointed you didn't answer the phone and tell her what you were doing. That's funny. So oftentimes what happens, that connective tissue gets sticky, and as we roll over top of it, it just kind of, that's that feeling initially is when we're breaking that abnormal bonds. And then what happens is sort of over the, you can even be a little tender because like you've had a deep massage there, and we've broken some of those bonds, and some of them over the next little while will sort of reattach, but hopefully most of them will reattach in a nice healthy position. And then the next time we do it, sorry, I'm talking to Genia. And then the next time we do it, it wouldn't hurt nearly as much. And then we just keep going until until we roll down there, or I roll down there, and my patient goes, doesn't hurt at all. I'm like, great, then I don't need to do it again. We'll check again in like a month or so, make sure it's fine. And but most people, sorry, I keep talking to Genia.
Okay.
There we go. Most people, I haven't had many recurrences. I'm coming up to sit with her.
Okay. I did remove the paper that I was just lying on for Liz. Okay. So, so what would you recommend for me?
For you, I would want to see, so if Genia was truly one of my patients, I would say,
phone call?
I would want to see Genia probably twice a week. We could do once a week with me, and there's a PT assistant, Allison, who has really specialized in the external portion of all this rolling. And she actually works a lot on the abdomen and on the legs, low back, and buttock, that same rolling technique. Because if you've got a lot of connective tissue in your abdomen, or like you've had a lot of surgeries or different things, your bladder can really become covered sort of with that gummed up connective tissue, and it doesn't expand properly, and it doesn't squeeze properly when you're going to the bathroom, and just freeing up sort of all the tissue on your stomach and on your legs and your low back can really make a difference, especially with urgency and pain. Okay. That interstitial cystitis really works well with the tummy rolling.
Okay. And how long would I likely need twice weekly treatments?
That's a really good question, and a lot of it would depend upon you. If you're really compliant with all your homework and do everything that you're supposed to do, it's very quick. If I've had patients that I usually would say, I think it might take about 6 weeks or so, and they're better in 4 weeks. I've had some people that I thought would take 6 to 8 weeks, and it's been 3 or 4 months because there's other priorities, right? Yeah. So
okay. So Liz, if people are in the Brockville area, where can they contact you?
You can call Seaway Physiotherapy. It's 613-925-2220, and our fax number is 613-925-2221. So 220 is our phone number, 925. Okay.
And we'll post this information in the notes section on this video as well. Now, if somebody is not in our community, how would they go about finding a pelvic physiotherapist?
I would Google it. There's or you could call or go on the website for the College of Physiotherapists of Ontario, and there should be a list of different pelvic physios. And you don't need, I just saw someone said, do you need a referral? We don't need a referral. Occasionally there is an insurance that does require a referral for a physiotherapist, but they're very rare. The best thing to do would be to call your insurance company just to see.
Okay. All right, wonderful. Cool. Okay, well, thank you very much, Liz.
Yes, you were so brave. You did awesome.
I will make a follow-up appointment.
Okay,
All right, thanks, everybody.
Bye, guys.
Bye-bye.